Hello everyone, my name is Jen Nolan and Musculoskeletal Australia is pleased to welcome you to our webinar this evening on the diagnosis and management of adhesive capsulitis, a musculoskeletal disorder frequently encountered in primary care settings. In addition to tonight's webinar, Musculoskeletal Australia has got some great webinars for the remainder of the year, as you can see by the list on your screens now. You can purchase the webinars individually or as a series, and the recordings of previous webinars are available for purchase at any time. Our presenter for this evening is Dr. Sarah Walmsley. Sarah is a musculoskeletal physiotherapist, currently working as both a clinician in private practice and as an academic at the University of Newcastle. Sarah's area of interest and expertise is in the management of shoulder disorders, and in particular the diagnosis and management of adhesive capsulitis. She has undertaken research in identifying clinical identifiers to facilitate early recognition of this disorder and has published and presented her research both nationally and internationally. Without further ado, I'll hand proceedings over to Sarah. Thanks very much, Sarah.
Thanks, Jen. Thank you very much, and thanks everyone for tuning in this evening to listen to my presentation. As Jen said, I'm a musculoskeletal physiotherapist and I'm both a clinician and an academic, and my passion is treating the shoulder and in particular frozen shoulder. So what I'm going to do this evening is go through and define adhesive capsulitis or frozen shoulder, discuss a little bit of the history and epidemiology, outline the pathophysiology as we understand it today, and then spend some time on working through how we diagnose frozen shoulder and then manage it, and then I'll wrap up at the end. So a few key points, and you'll hear me saying the similar things throughout the presentation, is that frozen shoulder or adhesive capsulitis remains a very poorly understood condition. It's frequently described as a waste can diagnosis because any patient that presents that's got a stiff and painful shoulder that no other diagnosis can be attributed to them, they're called a frozen shoulder or adhesive capsulitis. We know that the disorder or the condition involves considerable pain and ultimately movement restrictions, and it can have a very protracted course which affects the patient's function. One of the big issues with frozen shoulder or adhesive capsulitis, and again I'll be saying this a lot throughout the presentation, is that any of the research that has been done to date is notable by the fact that many studies have varying inclusion criteria for their subjects. So it makes drawing conclusions about a lot of the issues quite difficult. So just to go through a little bit about the history of this disorder, it's been around and been recognised since 1872 when Duplay called it periarthritis scapulohumeral. And subsequently, early last century, it was called frozen shoulder by Codman. Later on, in 1945, Navassier decided to call it adhesive capsulitis, and that was as a result of the fact that when he had operated on a number of patients, he observed that the capsule peeled off the head of the humerus like a sticking plaster, so he decided to call it adhesive capsulitis. Subsequently, adhesions haven't been demonstrated, and today the terms frozen shoulder and adhesive capsulitis are used interchangeably. A more correct term, and a term that is probably being used a little bit more frequently today, is to just call it a contracture of the shoulder. And more recently still, Jeremy Lewis, who's an English physio, he's actually an New Zealander but working in the UK, has determined that we should really be calling it frozen shoulder contracture syndrome. And I think throughout the presentation, although the title is adhesive capsulitis, I'll probably be referring to it as frozen shoulder just because it's sort of what most people understand. Just to run through a little bit about the epidemiology of this condition, and traditionally there's about a 2 to 5% incidence suggested in the general population. And if anyone's done any reading on frozen shoulder, you'll find that every paper that you start to read has, in the introduction, talks about this incidence, and really it's just something that's been handed down from paper to paper. It's been recently challenged, and Bunker in 2009 actually suggested that the incidence was more likely to be about 0.75. and that's because we can't really just regard it as the waist can diagnosis that it is. Again, traditionally, most people would recognise or would think that it's a mainly female predominant disorder. But again, that hasn't been borne out with a lot more of the recent literature. And in research that I have done, and certainly more of the better studies, would suggest that it's a 50-50 distribution. Genetic predisposition, has also been suggested. And whilst there's not really robust evidence of this, there are some links and there is some familial clustering. And interestingly enough, and I'll mention Dupuytren's in a little while, the genetic predisposition to Dupuytren's is also links in with the frozen shoulder. Again, the age group that is generally where this condition we see it is 40 to 60, so it's a middle-age kind of condition. Rare to see people under about 35, that would be the youngest that I've seen, and also rarer to see them sort of beyond early mid-70s. In fact, in Japan, this disorder is actually called the 50-year-old shoulder. Commonly involvement of the contralateral shoulder, and I certainly clinically see that. I think probably most people are aware that there is a significantly higher incidence in the diabetic population, and that's something that I really listen to in my patient history, or if they don't offer that, I will ask, because it's certainly we see it much more frequently in that population. There's also a number of coexisting diagnoses, including thyroid disorders, Dupuytren's, heart disease, TB, and interestingly, Parkinson's disease has also been suggested as a coexisting diagnosis. And again, I've recently taken an interest in Parkinson's disease presenting as an early presentation of Parkinson's being a frozen shoulder, and I've started to look at the literature about that. And again, this is something that I have probably missed clinically in the past, is that people have come in with what I have thought is a frozen shoulder. I have treated, and they've perhaps been resistant to treatment, and in the end, and I know this from a particular patient that I have who's actually a friend of mine, and the diagnosis was Parkinson's. And I think really with Parkinson's, it's probably an alteration of tone that mimics frozen shoulder. So I think that's something now that I'm a little bit more alerted to, that if people are not sort of quite fitting the characteristics that I'll talk about later, I might start to think about that as a potential. So I think the important thing about the epidemiology is that the traditional characteristics that we read at the beginning of every paper, I think we start to question those, as they're all based on a lot of earlier studies which have got perhaps poor methodology and limited evidence. And in particular, they are looking at heterogeneous populations, which is one of the big problems we have with research about frozen shoulder, that, if you like, apples aren't apples with all the subjects that they're including in these studies. So just keep that in mind, that it may not be as common as we think. Just talking a little bit about the terminology and classification. Frozen shoulder is broken down into basically two different classifications. The first being primary frozen shoulder, or idiopathic, which is when frozen shoulder comes on for no apparent reason. These patients present with an insidious onset of shoulder pain. They can't describe any activity that may have caused it, or any trauma, whether it be mild or not. And this is probably the group that we see the most, or that this is the group that I really think are true frozen shoulders. Most people don't describe some incident, but it's my opinion, and if it is reported in the literature, that a lot of people will, on really careful questioning, actually say, oh yes, I did do a little bit more of something, or I did fall some time ago. So maybe not that's always happens in the first consultation, but sometimes when they go away and come back, they say, oh, I've been thinking about that and I did do X, Y, and Z. So it certainly has been suggested that there can be a minor trauma that starts this, and that's what I feel, but that, again, hasn't been borne out with research. Secondary frozen shoulder is one that has a known cause, and maybe as a result of surgery, trauma, fracture, and these people frequently in studies are excluded, and I think that potentially they don't have the true hallmarks of the pathophysiology, which I'm going to discuss shortly. Also, the suggestion is that there should be a third classification being systemic, and within that classification, that people with diabetes and Dupuytren should sit rather than sitting with the primary or the secondary. So generally speaking, most of us recognise that frozen shoulder is classified in 3 stages, and that's the painful, the stiff, and then the resolution phase. And these have got a variable time frame, and I've just put in what again has been passed down from literature, throughout the literature, on the rough time frames. Certainly I don't think that I do think that the painful phase can go slightly longer in some patients. These are just sort of averages for the patients. Some authors, and they were earlier authors, have suggested that there are 4 stages, and what they do is they put a stage in before the painful stage, so it's sort of the pre-stage. And I think that is perhaps a useful classification, but I don't know that a lot of us in primary care see people when they're at that stage. Most people would tend to ride out the pain early on and not do much about it, just hoping that it will get better. More recently, however, 2 stages have been proposed. So as we learn more and as we're trying to streamline the knowledge about this condition, 2 stages have been proposed, and they're just labelled as pain predominant and stiffness predominant. And that tends to be what people are thinking about more. And I think what's really important for us to realise, and certainly for us to let our patients know, is that they're not clearly mapped out stages, that these kind of form a continuum and they sort of one merges into the other. So the natural history of frozen shoulder is reported to be towards resolution. So it's suggested that if we do nothing when patients present with this, that they will improve and they will get better. And again, this confounds some of the research that we read, because a lot of the studies subjects are being reported or patients are being reported to improve, but just how much of that is just due to time is unknown. Duration of the symptoms can be anything from 12 months to sort of 3.5 years, and it's also been suggested that the longer they have in that stiff frozen phase, the longer they're going to take to resolve. Although a lot of the earlier authors said that this condition did recover fully, there have been a couple of studies that have suggested that people do have a limitation of movement and or stiffness that is apparent later and sometime after the disorder. These studies are reasonably old, and I think perhaps longer term follow-up on people that have had more contemporary treatment, this may not be the case. And certainly people that I see, if I see them again for something else, or if I see them with the contralateral shoulder frozen, they report, and on examination their previous frozen shoulder doesn't have any limitation of movement. Okay, so just to run through the pathophysiology of this disorder, and again the pathophysiology does remain controversial and inconclusive, and the research that we have on this is based on radiographic as well as histological studies. And again, one of the reasons why the pathophysiology is we don't really know exactly what's going on is because the subjects that have been used in these studies have got variations or significant differences in their inclusion criteria, in diagnostic classifications or diagnostic criteria in including subjects, and also in the timing of when these patients or subjects are assessed. And you can imagine that if someone is being examined in the early stage, it may well be that there's a difference in what we're going to see both radiologically and histologically than someone who's in a later contracted phase of the disorder. A lot of the studies are actually involved with recalcitrant patients in the later stages, and so therefore I think we have to be a little bit careful about how we can generalise. Certainly there is a suggestion of both inflammation and fibrosis of the joint capsule with an increase in fibroblasts, which then in turn contract and form scar tissue. Pathological studies have identified the presence of inflammatory cells as well, and that's more in the early stage. And so the suggestion is that it's the process of inflammation that proceeds on to scarring. And we have to keep all this in mind in terms of diagnosis and treatment, as I'll outline a little later. So on MRI, we can see thickening and fibrosis of the rotator interval, and I'll discuss that in a minute, coracohumeral ligament within the axillary recess, and also frequently there's synovitis around the long head of biceps, which is not particularly specific to frozen shoulder, but it is nevertheless quite apparent. In the later stages, when there is contraction of the capsule, there's frequently observed in MRI reduced joint volume, again, that would be seen in the later stages. Histologically, there's been some suggestion that the changes of the tissue is similar to Dupuytren's contracture, and this is interesting because Dupuytren's contracture is a disorder that is reportedly seen more frequently in men, and certainly is more frequently in an older age group. So some of the clinical characteristics of those patients are different, yet there's been histological evidence of the same tissue. So that's quite interesting. There's a formation in the early stages of new blood vessels in the synovial membrane and markedly in the rotator interval, which is the area that we're going to be mainly interested in. And also, and this could actually change the whole management and thinking of frozen shoulder, there's been a recent suggestion of an association between P. acnes, and that's more of an infective disorder. And if that is actually shown to be true, it could completely change how we manage this condition. But there's very little on that at the moment. So I mentioned the rotator interval, and for those of you that may need a little bit of refreshing on anatomy, rotator interval is an area that we refer to at the front of the shoulder. So it's bounded medially by the coracoid process. Superiorly, it's bounded by the inferior border of supraspinatus. Inferiorly, it's bound by the superior border of subscapularis, and then laterally by the biceps tendon. So this area is where histologically and in fact radiologically there's been changes noted with these patients. And if you think about that in terms of the anatomy, this area, if this becomes contracted, will obviously limit external rotation because it's stretching those anterior structures. So the rotator interval is very significant in frozen shoulder, both histologically and in terms of the restriction that it entails later in the disorder. So diagnosis. So obviously when we're going to be treating our patients, we need to come up with a diagnosis, and we need to be able to arrive at that and use it to inform our treatment. And this is my particular area of interest with frozen shoulder, and my particular area of interest is in early diagnosis, which I'll talk about shortly. But one of the main points and key problems we have with diagnosing frozen shoulder is that there still remains no gold standard by which we can diagnose it, and also by which we can inform research studies. So given that there is no gold standard, we have to base it on our history and clinical examination of the patient, and also on some radiological investigations. And I'm going to talk about that in a moment as well, the radiological investigations. So we basically need to be very clear on the history and our clinical examination. Diagnosis, I don't think, is very hard in the later stages when we have someone who can describe the progression of their problem. They present to us and they've got marked restriction of movement, and I think most people are probably fairly confident making a diagnosis then. But early on, in the early stages, and that's in the painful stage and in the four-stage classification, the stage before then, it's very difficult to diagnose, and it's also very easily confused with other shoulder presentations. And I think that the examination skills and the tests we have for testing tendinopathies in the shoulder have really poor specificity, and I think this adds to the fact that they're giving often false positives with those tests, and it could lead down an incorrect track. So very difficult to diagnose in the early stage, and it's often a diagnosis of exclusion. It's a diagnosis that we need to rule out supraspinatus tendinitis. We need to rule out osteoarthritis in particular, and calcific tendinitis. I don't think we can rule out bicipital tendinitis because it goes sort of hand in hand with quite a lot of shoulder disorders. So I certainly know that the patients that I see in my clinical practice, I'm frequently not seeing them early enough, and they have frequently been elsewhere and been diagnosed with a tendon issue, have had management for that, and they've just become progressively worse. And that was my frustration in starting the research that I did on frozen shoulder, because I think these people very frequently get diagnosed as having a supraspinatus tendinitis. They get treated with strengthening exercises, plus or minus subacromial cortisone injections, don't improve, and the patient gets frustrated, and they end up frequently on my doorstep. So I think we need to be quite a lot better at looking and diagnosing these people early. So just before I go on to some of the points that I look for in early diagnosis, I'll just talk a little bit about the radiology. And I think it's important that we understand that these patients do need an X-ray to eliminate osteoarthritis in particular. Osteoarthritis and frozen shoulder behave very, very similarly, other than the fact that a frozen shoulder will improve and osteoarthritis will progressively get worse. So we do need to rule out osteoarthritis, because the management of that will differ from that of frozen shoulder. I think other than an X-ray, very frequently further investigation confuses the issue. And certainly most patients in the region that I work in, which is the Hunter region, when they present to their primary care practitioner, they will be with shoulder pain. They very frequently are ordered an X-ray and an ultrasound. The X-ray hopefully doesn't show anything other than a normal X-ray, but the ultrasound nearly always will demonstrate something. And that's where I think a lot of the diagnosis goes wrong with these patients, is that they go down that the track of whatever has been shown up on ultrasound. And I think it's important for us all to remember that there's a very poor correlation between changes seen on imaging frequently and shoulder symptoms. And this is something that Jeremy Lewis is quite passionate about. And he quotes a study where 90 people over the age of 40 with no shoulder pain, who'd had no treatment at all, so they were completely asymptomatic. 50% of those people had rotator cuff tears on ultrasound. So that it's very often a false positive. There's another study that he quotes frequently, which was had much better methodology, and he had 96% of people that were asymptomatic, but he demonstrated that there was structural failure in, there were 51 subjects in this, and there was structural failure in 96% of those people. So just because someone shows tendon issues on ultrasound, it doesn't mean that's where their symptoms are coming from. And I think that is really, really important message. These people go get their ultrasound report, they go back to their practitioner, because frequently here that I read on the bottom of radiology reports is that impingement is noted, bunching, the bursal bunching, and a subacromial cortisone injection may help. And so they're led down that track, which frequently is incorrect. And not only does it frustrate the patient, it also means that their frozen shoulder is roaring along and they're not getting any better. So I think that's something that we all need to remember. Arthrograms can show reduced joint volume, but again, I think by the time a person gets to the stage where an arthrogram is going to show that, we can probably diagnose them clinically anyway. Doppler ultrasound has got an interesting role here, and there is potentially an emerging role for this. There was a study in 2005 with Lee et al., and he looked at 30 people, and these people had had symptoms for less than 12 months. And he was able to demonstrate that in 26 of those people that they had an increase in vascularity in the rotator interval. And that's consistent with there being inflammation in that area. I did, as part of a series of studies I looked at subjects who had symptoms for less than 9 months, and I examined them with a Doppler ultrasound, and I found results that were promising. They weren't significant, but a number of these patients, it wasn't a significant number, did have some increase in vascularity with Doppler ultrasound. And I have actually seen reports coming from radiologists that are reporting in just routine ultrasound scans that they're actually looking at the rotator interval with Doppler and reporting that. MRI, the population that I see tend not to have MRIs in the first instance, so although they might be a useful tool later on to demonstrate things, I think they add little to the clinical diagnosis, really, other than inconveniencing and potentially causing cost to the patient. If they're going to show something, it will be when we can already clearly see what's going on examination. So the clinical presentation. So these patients, their clinical presentation will differ depending on the stage, and that is unlike a lot of disorders that we see. It's not unlike some others, but I think with this condition, it is really important that we recognise that. It's going to be easy later on, as I've said, but not so easy early. So I'm just going to run through a few things that I think are important that we listen to with our patients first, and then I'll talk a little bit about what we examine. So the history I kind of touched on briefly, and the history can either be insidious or it can follow some sort of trauma surgery. Obviously, if there is a trauma, it's clear and the patient remembers that. But as I've said, a lot of people will report a minor incident, and I think we perhaps need to quiz that out a little bit. So the history of any incident is important, but more the history of how it came on in terms of time frame. And people will often describe the fact that they had some pain, they thought it would go away, they may or may not have sought some help, and it's getting progressively worse. They early on will describe pain as the main feature, and the location of the pain I think is important with these people. It's quite different if you quiz them and if you listen to the patient closely. Is different to tendinopathy pain, different to ACJ pain, different to cervical spine referred pain. These people refer to the pain in the mid-humeral area or the deltoid insertion region, and frequently they will, when I ask about, or when you ask about where their pain is, that's the area they grab. They get their contralateral hand and they'll put it sort of mid-humerus and they'll rub it and they'll say, it's here, this is where the pain is. And I think that differs from our other shoulder presentations. It's with supraspinatus pain, patients tend to point more specifically, and they'll point more to the end of the acromion. With ACJ pain, they're going to be pointing superiorly. With issues in the glenohumeral joints, such as osteoarthritis, people tend to they point to the actual glenohumeral area and describe a deep pain with that. With frozen shoulder, and I think this is particularly characteristic of the early stage, not only the location, but the quality and the type of pain they describe is different. And they describe a sickening ache-like pain. It can make them feel nauseous. It's constant. It's non-mechanical in nature. It's there all the time. It's worse with movement, but it's this nasty gnawing pain. It's rarely described as a shooting sharp pain. So listening to the way they describe that pain, I think, is important. It's aggravated by a lot of movements, by many movements, and things that patients will offer will be functional. They might report pain with overhead movements, which doesn't really single it out, because a lot of shoulder problems are painful with overhead movements. They'll quite commonly describe difficulty reaching behind, and so women doing upper bra, men perhaps getting seat belts, etc., and reaching the back seat of the car. Now, I don't know why every patient I seem to see with a frozen shoulder needs to reach into the back of the car, but they do, and it's something that they report. And I think that's because that movement involves extension, and I think that is also the beginning of stretching those anterior structures going back behind. The other, and I think this is very characteristic of frozen shoulder, is they get pain and it is severe and it is sickening, bringing to their knee kind of pain with quick movements. And I don't think most other shoulder problems result in that. A lot of patients will offer that. If they don't, I specifically ask about it. And it's one of the questions that if I'm starting to go down the track, this is what they've got, I will definitely ask that question. And I think that that's something that's really important. Investigations may or may not be useful. I've talked a little bit about those. I certainly want to exclude osteoarthritis, but other than that, I don't really rely on investigations to inform me at all in my clinical, in my diagnosis. Previous treatment is important, and quizzing about previous treatment is also very important. In terms of, have they been one of these poor souls that's gone down the tendinopathy treatment path when that isn't actually their issue? So a lot of these people that we see have had subacromial cortisone injections with little or no benefit usually, and they have undergone a series of strengthening exercises for their tendons and got progressively worse. And I think that's just because the natural history of frozen shoulder is rumbling along. Also, I think that it's my experience that if I give strengthening exercises to someone with a frozen shoulder, they do get worse as well. So the effect of any previous treatment, and in particular cortisone injections, it's been suggested that maybe even diagnostically using a subacromial cortisone injection to rule out impingement or tendinopathy may be worthwhile as a diagnostic tool. Just keeping that in mind. So because my area of interest is the early stage, and I thought that I can generally pick these people, I did a study, which was a Delphi study, which was an iterative study of asking consensus of a group of experts. So I asked, there was some medical professionals, there were specialist physiotherapists, people who were experts or are determined experts in musculoskeletal medicine. And we did a Delphi study which sought their opinion on what they thought were the necessary inclusion criteria or diagnostic criteria to diagnose frozen shoulder in its early stage. You can see here that as a result of those, there were questionnaires that I sent out, and we got feedback and we resent them to the same group of people. And we had a reasonable response rate for a questionnaire, which is you never get a good response rate. But we found we had these 8 clinical criteria or diagnostic criteria. And this is what the experts thought. So a strong component of night pain. Don't know that always differentiates, but it is important. Interestingly, the experts also came up with a marked increase in pain with rapid or unguarded movements. Patients disliked lying on that side, which again is fairly common with a lot of shoulder problems. Pain easily aggravated by movement, which I think if we quiz people can be quite characteristic of this. The age is probably no surprise. So those first set of criteria were sort of mainly related to pain. These last 3 were more about movement, and they decided that there was a global loss of both active and passive range of motion, and interestingly and significantly so, pain at the end of range in all directions. And I think that's important. Patients with tendon pain may have pain at the end of flexion and perhaps hand behind back or internal rotation, but not usually in external rotation. So the experts determined that they had to have pain at the end of range in all directions. And anecdotally, I mean, I clinically would agree with that. They also suggested that they required to have a global loss of glenohumeral joint movements. So not the movements that involve other movements like flexion, which involves some scapular movement as well. Abduction involves scapular movement, but just the actual glenohumeral joint movement will be lost. So thinking a little bit about the clinical presentation in terms of movement, and a lot of us as physios, or a lot of physios and medical practitioners will have heard of the capsular pattern that was described by Cyriax. And that pattern was such that external rotation will be greater than abduction, which will be greater than internal rotation. So there'll be a greater loss of external rotation than those other 2 in that sequence. And again, I did a study of subjects that were that I had classified as diagnosed with early frozen shoulder, and we didn't demonstrate that pattern, but what we did demonstrate was that these people, and they were under 9 months with painful shoulder, that external rotation in abduction was the most painful, active and passive range of motion. And that's something that I didn't do clinically always, examine these people in abduction and external rotation. But now if I'm a little unsure of their presentation and they have minimal restriction of movement, and it is very difficult to assess restriction of movement accurately if someone's in pain, I lie them down and I get their arm at 90 degrees abduction and just see what their external rotation is like with respect to range and with respect to pain. And if that is restricted and or painful, or both usually, that's really firming me up on my diagnosis. Later stages, it's easier, as I've said earlier, and there's various means of classifying these people, but essentially a painful restriction of active and passive ranges of motion in more than 2 planes, and certainly painful limitation of external rotation in neutral abduction, and also pain at the end of range of motion. And that's all ranges of motion, as I've said, for the early stage. Okay, so we've kind of run through how we, a little bit about the pathophysiology helps us understand why these people get restricted into external rotation. Some of the features that we look for in diagnosing these people. Now let's turn our attention a little bit to management. So as I've said, the natural progression of frozen shoulder is towards resolution, and I've also said that I think the treatment, or not just me, but treatment should depend on stage. It has been suggested that treatment in the early stage will reduce the overall morbidity, so that's where my interest started, and I think that whilst that's not been robustly found, certainly anecdotally, I think that is the case. We've got a number of options available to us for treatment: physiotherapy, we've got medications, injections, and surgery. And I'm just going to run through briefly about each of these. Okay, so physiotherapy is the most consistently prescribed treatment for contracture and to improve range in patients. And despite the lack of high-grade evidence supporting the use in frozen shoulders, there are many lower quality studies that do report benefits, so all is not lost with the physios. I've just listed a few bits and pieces here. High-grade mobilisation, or our Maitland mobilisations, may be more effective than low-grade, and that study looked at subjects or patients in the latter stage. Joint mobilisation and exercise were associated with better outcomes than ultrasound, and that probably doesn't surprise us. There's no differences between patients treated with physiotherapy and no treatment. That's a bit depressing. And then benign neglect has also been suggested. But again, I think with any of these studies, we have to remember that they haven't really been well thought out, or they've been well thought out, but they haven't sort of undergone close scrutiny because really of the heterogeneity of the population. And so making generalisations is quite difficult. And the other thing that I have thought about recently is I've been involved here as being the treating practitioner in a study on ankle techniques for ankle instability, and we had an active treatment as our active management, and we had a electrotherapy treatment as the placebo. It was a detuned machine, and I found that many patients, or most of the patients in both groups, reported subjective improvement. So I think the physio profession, medical profession, is learning a lot more about placebo. So I guess that could come into some of these the conclusions that have been drawn from these studies. So I think one of the other things, and this is interesting for me because it's something that we don't see a lot of in this country now, but shortwave diathermy has been suggested to perhaps have some benefit in stretching because it addresses that neovascularity in the early stage, and also laser therapy has been shown to be of some benefit. Again, these studies have got some limitations. Perhaps we need to get our shortwave machines out of the museums, but hopefully not. But they are using them in the UK to treat frozen shoulder. Oral medication Most patients are sort of dabbling with a bit of medication, and they haven't really been looked at in isolation. People will have medication, but generally it's in conjunction with something else. So my experience is that anti-inflammatory medication on its own does not help these patients, and they've often tried that as a first line. Oral steroid medication as well may have some suggested there may be some relief, but again, these studies are poor, and we don't know whether there'd be a particular time of study where this might be better. And as everyone's probably aware, there's some significant potential systemic side effects. Intra-articular injections, and this has been extensively looked at, and they are used extensively, and they certainly appear to provide better relief than placebo. Although again, and a little bit sadly, it's not been suggested to alter the long-term outcome. However, it has been suggested that they will improve pain and function in the short term, and it may be benefited further with physiotherapy. So it's been suggested that it'll be much more effective in the early stage, but that's not been proven with high-level evidence. Certainly anecdotally, and certainly where I work, that's what our patients are usually directed towards if they have significant pain as their early presentation. So cortisone injections certainly being used a lot, and I'll talk a little bit about a pathway in a moment. Hydrodilatation is something that people have probably heard about, and this involves increasing the capsular pressure to expand. And the big issue with studies in hydrodilatation are that they're confused because most of the subjects, the patients that are having hydrodilatation, are having other treatments at the same time, and also the hydrodilatation involves a corticosteroid as well as the saline to expand the capsule. So it's difficult to know which is actually resulting in the benefit. And firm conclusions have been unable to be drawn. There was a very recent study which looked at refractory patients and compared, so these were people that had actually failed just an ordinary cortisone injection, and they found that this combined with joint distension, they showed no difference in those outcome measures. So I think the jury is still out on hydrodilatation, but I think it potentially has a place, as I'll talk about in a moment, later in the disorder. MUA, manipulation under anaesthetic, used to see it previously, not seeing it quite as much, and I think possibly because we are recognising frozen shoulder early better, and I think there's numerous complications with manipulation under anaesthetic, so I don't know that there's really been a lot of good, robust evidence that it's the way to go, and I certainly, in this neck of the woods, don't see it as frequently as we used to. Surgery, now this is becoming more common, but again, there's a few studies, and they're not really strong, supported by strong methodology. Some of them with expert opinion, and they have supported the use of capsular release. And it's essentially the rotator interval is generally released. I think there's probably more work that may be done, but I would hope, really, being a physio, I guess, that patients don't need to go down this track, and perhaps we're just seeing frustration rather than need in terms of having arthroscopic surgery to release. And is it in fact the fact that these people then have intensive physiotherapy following the surgery, and the patients are sort of progressing towards natural resolution anyway, that they improve? And I think that's something that perhaps a really well thought out study needs to address. Interestingly, no, I probably haven't got time to discuss that one study, but just thinking a little bit about cost, and this bears in with the surgical side of things, is the cost. There was a cost and net effective analysis, and this was done in the UK, and I think it was quite a long analysis, and they basically came up with very little to conclude about the cost effectiveness. And I think we don't really have to think too hard to realise that it is more cost effective to the patient. There's less downtime if we can find these patients early and get them treated early, so they don't have to undergo more aggressive, invasive measures. So a cortisone injection in physiotherapy is going to be significantly more cost effective than a surgical procedure and time in hospital, and potentially a lot more time off work. What do the patients think about this? And there's been quite a nice little study where what patients really were concerned about was the pain. It was severe, couldn't understand it. They thought they might be dying of something sinister. They were inconvenienced by their range of motion. And one of the big things that this study pointed out, and I think we see it clinically, is that patients get confused and anxious in the lack of diagnosis or the misdiagnosis. And I see very annoyed people who come and they've been around the traps and not really had a clear diagnosis, and therefore they've wasted time and money potentially. I think the patients also identified that we didn't give them enough information. And I know from my point of view, once I think I'm pretty right with my diagnosis, I say to my patient, this is what you've got, this is why. I go through the whole process with them. I explain how this is how it presents, this is where your pain is, etc. And this is what's going to happen, it's going to get better. And I give them treatment, I give them, I certainly do exercises with my patients. But one of the main things that they say when they come back the next time, whether or not they've improved in range, is I just feel so much better because I know what's going on. So I think we need to keep our patients well informed. So what's the best practice? Stage-based. I think the evidence, and certainly anecdotally, would suggest early cortisone injection plus or minus physiotherapy. I would say plus physiotherapy. Range of motion exercises early on, potentially more aggressive passive mobilisation later. People who fail that, potentially hydrodilatation, arthroscopic release, but I don't see many patients going to that stage these days. There are some guidelines and pathways. The UK is very good with these. Physios have got are very well recognised in the UK and set up clear pathways. Physiotherapists, specialist physiotherapists are able to inject, and they have this is a little bit busy to see, but you might want to have a look at it later. They've got a clear pathway for specialist physios working whereby patients and they're treated initially with physio cortisone injection, which I haven't pointed out must go into the glenohumeral joint. So when patients are having cortisone injections, they are not to be subacromially because that is not where the pathology is. So any patient that you're suggesting to have an injection must be intra-articular, and that's something that I highlight to my patients if they're going back to their general practitioner. It's no good just having a shoulder injection. It must go into the glenohumeral joint capsule, not subacromially. Otherwise, they will go down that wrong garden path again. So in summary, it's a frequently condition that we see frequently, or is it really that frequent? Difficult to diagnose early. Hopefully I've given you a few tips on that. The treatment outcomes we have to date, I think, are confounded by the fact that there's been not consistent samples and different stages of the disorder. I think we need to treat our patients conservatively, and if we look at the research, there's no single treatment that's most effective. And as every study will have as their disclaimer at the end, we need larger prospective comparative studies with better inclusion criteria and better diagnostic, using a better diagnostic criteria to determine the optimal treatment. So there's lots of shoulder work to be done, and I've done a bit and certainly have an interest in doing some more, and I'm happy to answer any questions. Thank you.
Thanks very much, Sarah. That was such an interesting presentation, and as I said to you before the webinar, for someone who's had an experience of frozen shoulder, it was really fascinating to see the breadth and depth of the information that you provided this evening. There's a couple of questions that have come through, and I encourage anyone else who has questions this evening to type them into the chat box now. You did mention, the first question is around hydrodilation. You did mention it and sort of say that the evidence is a bit inconclusive around the benefits of hydrodilation. There was a question particularly around mobilisation and exercise, and whether hydrodilation is advisable. You said it might be more beneficial in the later stages, I think?
I think, yes. I think that if someone has got some restriction of movement, it may be of benefit. I think the evidence is equivocal. I don't know that it has been shown from a research point of view that it is any better than cortisone on its own and exercise. I think that is the way I interpret the research. They certainly do it in the UK on that pathway if people have been resistant to just treatment with cortisone initially. Don't know whether that answers that person's question.
Another question, Sarah, any favourite exercises to prescribe in the stiff versus painful stage?
So in the painful stage, I generally just encourage people with range of motion, and I will get them doing some physiological stretching, but I'll do it within their limits of pain. Some people are quite happy to push quite hard, but I suggest to people that they just moderate so that they don't exacerbate their pain. These people in the early stage are really irritable, and I'm not aggressive with them. I encourage movement. A lot of the time, the people have just been not moving at all because they fear that if they move, they're going to make it worse. And so just functional movement in the first instance within the limits of pain, plus or minus some stretching. Later on, I'm much more aggressive with them when pain is not the predominant feature, and I will get them stretching, physiological stretching, so into flexion, into hand behind back, into external rotation in abduction as well, and maybe, depending on the patient, some joint mobilisations, but I don't frequently personally do that. I might if I have someone who's very recalcitrant though.
Question, does the cortisone injection need to go into the capsule rather than the glenohumeral joints?
Oh, it's just an intra-articular injection. So the injection needs to go into the joint, not the capsule. Yes, into the joint, through the capsule, into the joint. And patients that I see have it done with an arthrogram, or they have it done under imaging, and you can clearly see the needle is actually in the joint. Yes.
And Sarah, your point about the sort of providing sufficient information to the patient is a very important one, especially from our perspective as a consumer-focused organisation. Is there any good written information around about frozen shoulder that would be available for clinicians to give to patients?
That's a good question, and I know the practice that I work at, we have our own written information. I don't know what is available in terms of what might be out in the general community or online. I think a lot of practices and a lot of medical practices, orthopaedic practices, do have patient information available, but I don't know. I don't know beyond that. I certainly know where I work, we have a brochure that we give our patients that outlines the course of the disorder.
And another question I have, just in relation to some of the research behind, you've commented several times tonight about the variations in some of the study populations, which has made it very difficult to sort of draw conclusions or provide a high level of evidence. Is there any sort of approach internationally to try to have a greater consistency around the inclusion criteria for various studies that are being undertaken?
I think that's a really good point, and everyone comments on that, and every study that will use that as a limitation frequently, that they only use X population. I think until we have a clear gold standard for diagnosis, it makes it really tricky to what you use as your inclusion and exclusion criteria. And I think the point here is that some studies will have people that have got a stiff shoulder following surgery, and I would argue that they're probably not really the true frozen shoulder. And so it depends on, I think you have to be very careful when you're interpreting any of this literature on who they did include and at what time frame they included them. So really, a really large study that you are including a lot of people and a lot of different treatments potentially would give valuable information, but they're not around. Everyone just does their own little study and uses their own criteria based on what they think are the inclusion criteria for the patient. So, for example, some people might say they have to have more than 2 ranges of motion restricted. Other people might say just external rotation. So how they define frozen shoulder in terms of the criteria vary. That's the point there.
Another couple of questions. Do you treat frequently and do you continue to treat to resolution?
A good question. Myself, clinically, I inform my patient, I get them on a treatment program, I review them at intervals. I treat them hands-on if I need to, but not that often these days. And I wait until I think that person is pretty close to resolution, certainly out of the painful phase. It depends on the patient. Most people I wouldn't see right to the bitter end because they and I feel that they are confident to continue. I tell them to continue the exercises until they have right equals left and it's pain-free. If they don't get that within a couple of months, I suggest they come back, and I rarely see them back.
And could be just about our last question, unless people hurry up and type in their questions now. Is there much evidence re hormonal changes being involved in the condition of frozen shoulder?
That is something that has been suggested because of the age group and because of the suggested greater number of women involved. But I think that in those couple of studies where they have questioned the female predisposition, I think that questions the hormonal influence. There has been a little bit of research. I don't know that it has come with any results have been particularly concrete. But I don't know the specific answer to that. But I haven't read a lot about it. I have read that it has been suggested, but I don't know that it has been really pursued.
Mm-hmm. Well, Sarah, I think I know we've got one last question. Heat or ice indicated in the acute stage?
Okay. I'm not a fan of ice when people have pain, so I would say heat. That's just my opinion. I haven't actually read any studies that do describe using ice. I don't think, although it's inflammatory, I think it is sort of deep inflammatory. I don't know that ice would be effective. I don't know. If that person's a physiotherapist and a clinician, they might like to try it, but I don't think my patients would think too kindly about ice when they've got a painful shoulder. Most people like heat, and heat certainly helps in terms of making tissues a little bit more elastic for stretching, which is what we're trying to do.
Well, Sarah, on that note, that was just a fabulous presentation this evening. Thank you so much. And could I thank everyone who has joined us this evening as well. Also remind you about our next webinar, which will be screening on Tuesday the 25th of September on the topic of diagnosis and management approaches to musculoskeletal related headaches. So could you please tune into that? You'll be receiving further information about that forthcoming webinar. On that note, I'd like to thank everyone for joining us this evening. Thank you again, Sarah. And if everyone could take a moment to answer the questions just as part of the exit survey, that would be fabulous. And I think it's been a really great webinar this evening. So on that note, I wish everyone a good night. Thank you.